The sympathetic nervous system, for example, controls your activity, correct? And the parasympathetic nervous system controls you when you are calm, correct? Yes, that's rest state. Do you know their effects in the digestive system and also in the urinary system? Because this is part of your question. Think about it this way. When you are running, that is activity. Do you feel like pooing or do you feel like urinating? No. It means that the sympathetic nervous system, which controls activity, reduces the effect of the urinary system. So it works opposite way in both the urinary system and the digestive system. Why the parasympathetic nervous system that controls you when you are at rest increases it because that's when you want to poo. That's when you want to wee. I don't know if you understand. Anatomy is what? Location, location, location. Physiology is function, function, function. So today we are discussing the urinary system anatomy and the physiology. I want you to pay rapt attention because we are going to discuss a whole lot of questions. Mind you, I don't want to talk so much, you understand? So I want us to focus squarely on the issue at hand, which is discussing a lot of questions. We are going to broach a lot of things during this discussion. We're going to review some slides during this discussion. But the head word is I want us to study about 80 questions in urinary system. And these 80 questions will be questions that definitely you will definitely see in your college exams. So stay tuned to my channel, all right, from beginning to the ending of this video. You don't need to fast forward. What you need to do is to get a paper and a pen, keep it beside you, and any question I discuss, write it down because you are definitely going to see this question as far as college is concerned. So this video is for everyone in biology department, both anatomy, physiology, both pre-medicals, both pre-nursing or nursing students, as far as you're in the US or outside the US, this video is for you. So I want you to pay attention, click on subscription button, share the link of this video, make comments. The most important thing, make comments. If there's a fact that you didn't like the way I answered it, just make comment under it. If you want me to improve this video, make comments. If you want me, to do a certain topic for you that is difficult for you to understand, make comments under this video. Also click like, all right? So let's jump into this video now and look at these concepts. Looking at your slide, you will understand what I mean by, I want us to understand the difference between nephrology and urology. So nephrology is the branch of science that deals with the study of structure, function, and diseases of kidney. While urology deals with, that urinary system itself. So one deals with anatomy and physiology, while the other one deals with specifically male and female urinary systems. I need you to put that in your head because that's one of the questions they will ask you. Another thing you need to know is the different functions of the urinary system. I'm not going to read all these things, but I need you to just understand them. One is excretion, another one is elimination, another one is also to regulate volume pressure. Another one is to regulate the electrolytes to release hormones. Which specific hormones? Erythropoietin. What does it do? Hematopoiesis. Which other hormone? Renin. What does it do? Pressure regulation. Which other hormone? Calcitrol. What does it do? To activate absorption of calcium from the intestine. So calcitrol is an active form of vitamin D. All right? These are the kind of questions they will ask you. Little questions, in between line questions. Now, let us look at the organs itself. Now, the urinary system, we have the kidneys, the ureters, the urinary bladder, and urethra. What you need to know, understand, is the difference between the ureter and the urethra. Very, very important. This is the ureter. Ureters, urethra. If you look at this, you see the ureter. So the ureter connects picks urine from the kidney, where it's produced, down to the bladder, where it is stored. Then the urethra, CHRA, brings it out, either through the female or the male genital tract. I don't know if you understand. So urethra, extra, external, extra. But ureter, inter, between two organs, which is the kidney and also the urinary bladder. You can't forget this now. You can't forget this. Okay, because I want to be very fast. Remember that the kidney is located posteriorly, right? Posteriorly. And because it's located posteriorly, it's located against the dorsal wall on either part of the spine. Now, this question always comes out in right kidney is slightly lower than the left kidney. The question is why? Why? Why is this right kidney lower than the left kidney? If they ask you in exam, it is because the liver is impressing itself on the kidney, so pushing it down a little. Now, if you look at this yellow organ here, this is the adrenal gland. We are still going to discuss that later. Now, the structure of the kidney itself. You have the length, width, thickness, and the weight. You need to know these things, especially the weight. It's 150 grams. Also, another anatomical landmark I need you to know is this. The left kidney is between the T12 to L3. T12 to L3. T1, 2, 3. In class, I mentioned it as T1, 2, 3. T1, 2, 3. T1, 2, 3. So T12, L3. If you see this in the option, please pick it up. Pick it up. Now, remember the kidney is bean-shaped. Bean-shaped. That's another thing you need to know. And the kidney has two major structures in it, which is the renal cortex and the inner medulla. Let's look at it more. So the functions of the kidney, we've already discussed. This one is just, total breakdown of the kidney. You understand? Now, when coming back to the functions of the kidney, the major functions of the kidney is excretion of nitrogenous waste from the body, correct? Correct? Yes. Now, nitrogenous waste is very, very, very important for it to be excreted in the body. And why is this so? This is so because urea, ammonia, creatinine, all of these are nitrogenous waste. If these nitrogenous wastes are allowed to accumulate in the body, it becomes toxic to the body, leading to what we know as azothermia. So azothermia, you see it in your exams. They will ask you, which of these results from non-excretion of nitrogenous waste in the body, or which of these results from kidney breakdown? Azothermia. And azothermia is when there is high nitrogenous waste products in the system. All right. So the kidney also regulates blood volume. We discussed that. pH balance. We will discuss that. Blood pressure. We will discuss that. Regulates red blood cell production. We've mentioned erythropoietin. Correct. Now look at the kidney itself. Another question they usually ask is about this helium. This is the helium. The helium is this concave notch. You see, concave notch of the kidney where the renal artery. They will ask you what passes through the helium. The renal artery, the renal vein, the nerves, the ureter, and the lymphatic vessels. You see that? So this is the artery. We call it VAN, van, vein, artery, and nerves. Then this ureter also passes through it. So even the lymph nodes, all of them converge. So these things passes through the helium. I will show you questions on that. Now, coming to the kidney, when we dissect the kidney, if you open up the kidney, this is the cortex, the external part of it. Then this is the medulla. You understand? Now, blood waste enters through the renal artery and are filtered through the renal vein. Now, when they are, after filtration, the excess water and toxic waste leaves through ureter, urine. I need you to understand this. Let's talk about the nephron. I'm trying to be very fast, all right? The nephron is the microscopic structural functional unit of the kidney. It's composed of renal corpuscle and a renal tube. Renal corpuscle and renal tube. Renal corpuscle and renal tube. How many times did I mention this? 3. This is how important the nephron is. Know that the nephron is the smallest unit of the kidney. It's just like me telling you what is the smallest unit of life. Cell. All right? Cell. That's exactly how nephron is. Smallest unit of the kidney. In the nervous system, we call it neuron. In the urinary system, we call it nephron. I'm trying to give you comparison so that you will understand what nephron is. So nephron can exist alone, structurally, and also can function properly. Okay. Now, talking about the capsule, what is the renal capsule? Capsule is just a protective layer. Look at it, you see? It's just a protective layer of connective tissue surrounding the kidney. Do you understand? What it does is to stop infections, from spreading within the kidney. So this is a total, when you cut it, this is capsule, you understand? Then the second one is, that we mentioned, is the tubules. So, when you open so this is the capsule, this is the nephron, you see? This is the nephron, this is the tubules of the nephron. So we are going to discuss this. Another thing I need you to look at is this structure, this diagram. Look at it very well. Put it in your head. This is the minor calyx. This is leading into the major calyx. The major calyx leads into the renal pelvis. So minor calyx leads into the major calyx leads into the renal pelvis. Renal pelvis becomes the ureter. You get it? But still know that the renal medulla, this is in the internal is medulla. But this thing is a pyramid. The renal pyramid enters into the minor calyx. The pyramid
Look at it. A lot of pyramids becomes a minor calyx. 2 or more minor calyxes becomes the 2 or more minor enters the major calyx. 2 or more minor calyxes enter the major calyxes. The major calyx now, and 2 or more, 1, 2, 3, 4, 5, becomes the renal pelvis. 1 renal pelvis becomes ureter. Okay, so the renal capsule is the internal layer. So when you cut it open, you see this is the renal capsule. All this place we call it parenchyma, but this is the renal capsule. Capsule is just a protective layer. Remember that, just a protective layer. Now, if you open this parenchyma of the kidney, you will see that this is the cortex, and all this internal part is the medulla. Why this external part is the cortex? You see the diagram, this cortex. All this place is medulla. Now, if you look at this medulla, you will see that this is where the nephrons in between the cortex and the medulla. Now, you look at it properly, you see that this is renal pyramid. This renal pyramid leads into a lot of renal pyramids. 1, 3, 4, 5, 6, 7, 8. These renal pyramids, a lot of them, 20 of them. They enter into the, this is the renal papillae. From there, they enter the minor calyx. You understand? From the minor calyx, they now enter the major calyx. So 2 or more minor calyxes make up the major calyx. Many major calyxes join together to make up the renal pelvis, and the renal pelvis now enters and becomes the renal ureter. I need you to understand this. But know that the major function of the renal capsule is protection. Now, as we continue, there are 3 regions of the kidney. We've already discussed this. The renal cortex, we discussed the cortex, we discussed the medulla, we discussed the renal pelvis. This is just for emphasis sake. Now, when you are talking about the cortex is the outermost region of the kidney that contains the Bowman's capsule. You understand? This is the cortex. This outermost part is the cortex. It contains the Bowman's capsule, collecting duct, the nephron, and site for ultrafiltration. All right? I believe you know this diagram. You really need to put this diagram in your head. Honestly, it will help you answer a whole lot of questions. Why the renal medulla is already the internal part, made up of the pyramids, a lot of pyramids. So all these things are pyramids. You see? Pyramids. All of them are pyramids. We already know the pelvis. This is renal pelvis. Remember, this is the helium. Very important to know the contents of the helium. I've already mentioned it initially. Now, we have the minor calyces as well. Minor calyces. So this is calyces. All these ones are the minor. So you need to know how to label. So minor calyces lead into the major calyces. All right? Okay. Now, when you talk about calyces, you read from the minor calyces, all of them converge to form the renal pelvis. So this is minor. All of them join to form major. All these major join to form pelvis. Pelvis now join to form ureter. Now the ureters I've mentioned initially, this is the ureter. They carry urine from here to here, here to here. One beautiful thing you need to know about the ureter is that the ureter is not transitional. One beautiful thing you need to know about the ureter is that the ureter is transitional epithelium. They may ask you in exam. Transitional. I'm saying it a whole lot of times so that you will remember. It is transitional because it stretches. The same thing with the bladder. Transition, it stretches. But inside the kidney, you understand, you talk about the cuboidal. A lot of the structures, they are cuboidal because they make urine. Cuboid, cup, drink, water, cup, drink. So I told you that most glands, most things that make up urine or make up liquids, you understand, cuboidal. Always remember that. It helps you. And also know that urinary bladder stores urine. You understand? And urine moves through gravity and peristalsis. Now, open the bladder properly. The bladder, is smooth, collapsible muscular sac, just like the stomach. It has rugae. It has a lot of rugae. Now, it has these secretory holes. Always put that into perspective. Then this smooth part is known as a trigon. They will point it and they will ask you, what is it? It is trigon. Write it down. Trigon. All right? Now, this is more diagrammatic surface of the bladder. Remember, I told you the bladder is transitional because it stretches. Transitional, transiting between cuboidal to columnar. It's transitional. All right? It has lamina propria, it has submucosa as well. Now, The bladder has the detrusor muscle. They will ask you which muscle do we have in the bladder. Please remember, it is the detrusor. It is the detrusor. It helps to propel, helps to push out, contract, and expand. Now, this is urethral openings I mentioned initially, and this is the trigon. I still mention this trigon again. This is internal sphincter, urethral sphincter. This is external urethral sphincter. What do these sphincters do? They, sometimes you want to urinate, you're on the road, you want to urinate. What happens? You have to hold it with the bladder. Same thing happens when you want to poo. If you are not in a place to do it, what do? You hold it. You understand? Using the internal and the external urethral sphincter, you hold it, you constrict this place. Okay. Now, more diagrams. I told you I love diagrams. This is more diagram. This is a trigon. Don't forget. I have to label this trigon here. Don't forget. This is a trigon. All right? Now, the bladder, collects urine, correct? We say that in adults, your bladder can contain up to 500 to 700 mils, not just 600, 5 to 700 mils, even a little more. The bladder is retroperitoneal. The bladder is, even the kidney is retroperitoneal. I forgot to mention that. What do I mean by retroperitoneal? It is held at the posterior abdominal wall. In front of it, you see the mesentery, pinning it to the abdominal wall. Correct? So it's retroperitoneal. Most of the urinary system organs are retroperitoneal. So always remember that. All right? Most of the urinary system, they are retroperitoneal. Always put that into perspective. Another thing you need to know is that during pregnancy, the capacity is reduced due to compression by the enlarging uterus, resulting in increased frequency of urination. That's why pregnant women always urinate a lot. And it lies anterior to the uterus in the female. Why, in the female? Okay. Now, let's talk about the urethra. The urethra is a thin-walled tube that carries urine. I mentioned initially, this is urethra. This is urethra. This is urethra. So it carries urine from the blood outside. For the male, outside, that hole in between the penis is the urethra. It is longer for male, you see, almost 18 to 24 cm. It's longer in males. While in females, it's so short, 3 to 4. So short. And because of this, it's so short. And because of this, what happens? There is higher chances of infection in females than male. Think about it now. If infection enters there, before it climb, and get to the bladder, it would have died. It would starve. But here, it's just, this is so short. It will just climb to the bladder and cause ascending infection. All right? Now, the urethra, I've mentioned this. I've mentioned between 18 to 24, females 3 to 4. I've mentioned this. Now, the nephrons properly, the structural and functional units of the kidney, as we mentioned before, it helps to filter blood and urine formation, correct? The urethra has about 1 million to 1.2 million. In your exam, you will see 1.2 million. Please pick it up. 1.2 million, the urethra, the nephrons rather. So each kidney composed of 1.2 million nephrons in an adult. 1.2 million. Here I said 1 million, but please, 1.2 million. Now, there are two types of nephron. We have the cortical nephron and we have the juxtaglomerular nephrons. The cortical nephrons, the one in the cortex, look at it, cortical nephrons. See? Cortical nephrons. This is the juxtaglomerular nephron, just at the medulla. So this is the medulla. This is the medulla here. So this is just, around the medulla. Sorry. So there are two types of nephrons. We have the cortical nephrons and with the juxtamedullary nephrons. Now, 85% of nephrons, the cortical nephron. This is cortical nephron, you see? While the remaining, the medulla, juxtamedullary nephron, you see? Just around the medulla. Just at the medulla. Juxtamedullary. See? Just around here. And it's just 15%. For real, it's just 15%. Why this is 85% of all nephrons, meaning that majority part of the urine is produced at the cortex, in case of it, they ask you. But we are going to enter the juicy part of this discussion. Now, these are the parts of the nephron. This is called nephron structure. So we have, look at it. This is the renal arteries, the one that enters afferents, the one that goes out efferent, efferent, afferent, efferent, afferent, efferent. We are still going to discuss them more. So this is the glomerulus. Why this is the Bowman's capsule? This is the glomerulus. Why this is the Bowman's capsule? You know, this is proximal convoluted tubule. The urine, the filtration comes down. So this is the nephrons. This is not typical structure of a nephron. I just wanted to put it in your head. So this is the arteries, both the afferent and the efferent. This is the glomerulus. This is Bowman's capsule. Urine comes down. This proximal convoluted tubule. From there, it goes down the loop of Henle. It climbs up, ascending up. This is the descending part of the loop, and this is the ascending part of the loop. It climbs up. This is the distal tubule, DCT, and this is the collecting duct. What you should know in case of the answer is the collecting duct part of nephron? No. Is the collecting duct part of nephron? No. Is the collecting duct part of nephron? No. So this is the collecting duct. It's collecting from this nephron. This part is collecting from another nephron, another nephron, another nephron, another nephron. And all the urine enters here, passes down the ureter. I needed to put this in perspective. This is the internal structure of the nephron, how blood flows in and out of the nephron. I will still get to a more juicy part of this discussion. Let's talk about urine formation. Now, this is the renal corpuscle. I need you to understand something. First of all, this is proximal convoluted tubule. Why? This is afferent. Do you see how big the afferent is? This is efferent. So the efferent blood enters inside, circulates, then goes out through the E. So what do I want you to get here? Look at it. The efferent is so big. The efferent is so small. What does it mean? It means that pressure will build up here. I'm using this opportunity to teach you the pressures. Pressure will build up here. You understand? So this pressure here amounts to 60, right? It will build a lot of pressure here. This amounts to the external pressure. The internal pressure is about 60. The external pressure is about 18 and 32. If you add it up, everything amounts to 50. So the net filtration pressure is 10. So because this net, how you will be able to understand it? Just visualize a class. If you are inside a class, we have a very big door. That door allows a lot of people to come in. Then we have a very microscopic door. You understand? You can't even go out if you really want to go out. Like very tiny people will be able to pass out of that door. What happens? People are just entering into the class. Before you know it, the class is filled. More people are entering, high pressure. So what do? Will people wait to lift through the door? No. Some people want to jump out the window. Jumping out the window is called filtration. Why? Because the pressure inside is greater than pressure outside. Now the pressure outside holding people inside the class is around 50. Why you understand? It's around 50. Why the pressure inside, the hydrostatic pressure inside is almost around 60. So if you do minus 60 from 60, it becomes 10, meaning that the pressure inside is winning the one outside by 10. So what does it do? That 10 will push out a lot of things through the window. Pushing out through the window is filtration through the tubule. So imagine that window as tubule, filtration. The big door as afferent, the small door as efferent. Big door as afferent, the small door as efferent. So blood enters through the big door, efferent, stays into the glomerulus, that's the Bowman's capsule, which is the class, then is living through the efferent, but it's living very slowly. So a lot of pressure here. We now push, fluid, through the tubule. That excess temp pressure, millimeter mercury, we push fluid through the tubule. Right? So a lot of fluid, about 180 liters will go out through the tubule. So if this 180 liters goes out, what happens? That leads us to urine, everything about the urine, filtration. It leads to filtration. So look at it. So this is where the pressure, this is the window I'm talking about. So this is the big door, afferent. This is the small door, efferent. So a lot of blood enters here, but very few is able to leave. So what happens? It creates a high internal pressure here. That internal pressure is greater than the pressure outside, the oncotic pressure outside, by almost 10. Because this 18 and 32 is 50. You don't worry about the pressure. So why this is 60? Hydrostatic pressure will be about 60. So the excess of 10, we push things through this window. This is the door. This is the window. This is the window. This is the tubule. This is what we are going to discuss. This is the tubule. Now, this thing is called filtration. It's called filtration. So fluid from blood plasma, such as minus protein blood. So there are things that could not be filtered, are not filtered. What are they? Anything that is greater than 8 nm nanometer, anything greater than 8 nanometer cannot be filtered. Do you understand? Anything, just think about, put it that way in your head. Anything that's greater than 8 nm, like what? Like proteins. Like what? Like blood. Even hormones that are attached to proteins cannot be filtered. Vitamins that are attached to proteins cannot be filtered. Meaning that if somebody comes to my hospital and I see blood in the urine, I know that there's something wrong up there in the kidney. Something has to be wrong for the person to be bringing out, for this thing to filter urine, filter blood into the urine. Or if somebody comes and I see protein, then there's a problem. A good functional kidney cannot allow protein or blood to pass through it. But what are the things that could pass through it? A lot of things, like water, like salt, like vitamins. Do you get sodium, even glucose? A whole lot of things will pass through it. So all these things are called filtration. Filtration. Now, what happens after filtration? So this filtration happens here, correct? After filtration, the blood is now coming out through the efferent, you see, and the blood is reduced. Why? Because a lot of things were taken away from the blood, and the blood is angry. Why did you take a lot of things from me? Please give me back my products. Give me back my products. That is called reabsorption. The blood is now taking backwards things that naturally the things that were filtered in it initially. So that's why you filter almost 180 liters, but yet blood will take almost everything back. Because somebody was asking me in class one time, oh, we can filter almost 180 liters. Then why don't we urinate 180 liters? The truth of the matter is that you don't urinate 180 liters because the blood decided to take everything back to itself. That is called what? So the blood is taking back what? Solutes. Like what? Glucose goes back, sodium goes back, potassium goes back, magnesium goes back, phosphorus goes back, bicarbonate goes back. Virtually everything goes back. The only thing that does not go back is hydrogen. It pushes hydrogen out. But this is reabsorption, taken back in. I need you to put that in your head. The location for reabsorption is the PCT and also the loop of Henle. So PCT and the loop of Henle. But if they ask you what is the location for filtration, tell them it is the renal corpuscle. That is where filtration happens. This place, renal corpuscle, that's where filtration happens. But if it is after filtration, blood is taking things back through what? The proximal convoluted tube, loop of Henle. Proximal convoluted tube, a lot of things goes back to the blood. All right. So that moves on to secretion. Now, blood has taken a lot of things back. And now blood has said, oh, I took things like hydrogen. I took things like creatinine. I took some drugs in. I need to push them out. Secretion. Oh yeah, take back the waste products. That's secretion. So remember the protocol. The blood reabsorbs, takes back to itself its product. And later, there are some waste that are still in the blood. The blood gives it back. That giving back is secretion. Giving back is secretion. Giving back is secretion. It happens in the distal convoluted tubule, DCT. DCT. So if you look at this diagram very well, you see that filtration occurs here in the renal corpuscle. Filtration occurs here. Now the fluid is coming back. What happens in the PCT and the loop of Henle? The blood what reabsorbs, and after that, the fluid is going up. The blood decides to give it back some of the hydrogen, give it back hydrogen, give it creatinine, give it potassium, and drugs back into the urine in the DCT. This is the DCT. Then when it has given it back, the urine now pours into the collecting tube. So that is what urine formation is all about. Do you understand? I don't want to go into telling you about potassium, hydrogen. Those things are very good. They regulate how urine flow in the blood, but they don't really need to, it's not really much of a compulsory that I should start teaching you that now. What I'm focusing on is how you are able to pass your exams. Simple. Pass your exams. Some of the things you don't know, learn it later. Some of them you are even going to learn it on the job. Now, to recap everything I just discussed, the glomerulus filters blood, proximal tubules, reabsorption of filtration and secretion into the tubule, loop of Henle, concentration of the urine, distal, modification of the urine, collecting duct, final modification of the urine. This is where all these things happen. This is still discussing things that are actively reabsorbed. Things that are actively reabsorbed. If you need this slide, just tell me, drop it to you in the comment section, all right? Okay. This is the nephron, in its entirety. This is just a recap of the entire thing. This is the efferent, blood goes in, afferent, blood comes out, correct? This is the glomerulus, This is the Bowman's capsule. Filtration goes in through here. You see, this is capsule space. Filtration goes here. Proximal convoluted tubule, then goes down, descending, thin descending limb. And one other question that you need to remember in this thin descending limb is that the thin descending limb is squamous. The epithelium is squamous. That's why it's flat. A lot of water goes out from it. Other parts cuboidal, but this is squamous. We'll discuss that. So this is thin descending limb, ascending limb. This is thick ascending limb. Then this is the DCT, distal convoluted tubule. What happens in the DCT? Look at it. Oh, in the PCT, reabsorption of water, ions, and all organic nutrients. But in the DCT, secretion of ions, acids, drugs, toxins, secretion, remember. And after that, it enters the urine. This collecting ducts, you understand, a lot of things, going out and in of the collecting duct. The collecting duct enters through the papillary duct into the minor calyx, minor to major calyx, major to pelvis, pelvis to ureter. All right. So this is everything that happens in the nephron. I've already told you this. You see, this is the nephron. You understand? It does everything it does. The entire reabsorption, secretion, and water conservation. Does everything, then collects it to the collecting duct. Collecting duct passes through the papillary duct in the renal pyramid. Then the urine now enters through the minor calyx. This is the minor calyx, which opens into the major calyx. Major calyx enters into the renal pelvis, which now drops the contents into the ureter. Then from there, the bladder. So this is pretty straightforward. This is the countercurrent mechanism, all right? The countercurrent mechanism. Just know that the countercurrent mechanism is used to concentrate urine. It's how sodium ion, and how ions goes out and water follows it. It's as simple as that. So if you notice here now, you see a lot of glucose is flowing out, amino acid is flowing out, potassium is flowing out, calcium is flowing out. What do you think will happen? Water will keep flowing it out. And what happens? Osmolality will increase. So osmolality is reduced here, 300, 400, 500, 600, 700, 800, or here almost 1,200 osmolarity. That's the countercurrent mechanism. Do you understand? Now osmolarity increases. Now here, what happens? Sodium starts going out. If sodium starts going out, that means the salt level is reducing. So what happens? The osmolarity starts reducing. The least osmolarity around 100 is in the distal convoluted tubule before it enters the urine. Okay. Now let's talk about the hormonal mechanisms in the kidney. First of all, we talk about antidiuretic hormone. What does it do? It helps to decrease urine production, decrease sweating, and increase blood pressure. It's produced in the posterior pituitary. You understand? And when it's produced, what does it do? It activates the kidney to produce aldosterone in the adrenal glands. So first of all, the role of antidiuretic hormone, I don't want to go into this. I just want to mention it briefly. For urine production, decreasing sweat, and increasing blood pressure. Urine production, decreasing sweat, increasing blood pressure. We see questions on this. So when there is somebody is dehydrated, what happens? ADH is released. Why? If your ADH is released, it wants to decrease urine production because you need water. It will decrease the amount of water you are losing because it needs water. It will increase your blood pressure so that blood will start flowing faster. But overhydration needs ADH inhibition. Now, this is a renin angiotensin aldosterone system. I want to also mention to you RAA system. What happens? I'll just mention this briefly. Now, if there is dehydration or sodium deficiency or there is hemorrhage, maybe somebody that has an accident, what happens? The blood volume will decrease, correct? When blood volume decreases, what happens? There will be decrease in blood pressure. This decrease in blood pressure will lead to what? Activation of the cells, juxtaglomerular cells of the kidney, correct? This activation will increase what? Renin. So if they ask you where is renin produced in the juxtaglomerular cells of the kidney. Renin is produced. Now, what does this renin do? Renin will break down angiotensinogen from the liver. What did I tell you about gene? Pepsinogen, zymogen in digestive system. I told you that anything gene is inactive. Inactive. So what does this renin do? Renin will break this thing, amino acid down, our 453 amino acids in angiotensinogen. It will break it down to about 10 amino acids. So the renin will break down angiotensinogen to angiotensin 1. So angiotensin 1 will now be broken further to angiotensin 2. How is it broken further? Now the lungs will produce ACE, angiotensin converting enzyme. We convert angiotensin 1 to angiotensin 2. So the question is, why is the kidney and the lungs stressing and the liver stressing themselves doing all these things? It is so that, it will lead to vasoconstriction of arteries. It will lead to, before even this vasoconstriction of arteries, the major thing it will lead to is this adrenal cortex, activation of this adrenal cortex. When it activates adrenal cortex, what does it do? It will lead to what? It will lead to increased aldosterone. Increased aldosterone. Increased aldosterone. Now, if aldosterone is increased, which is another hormone produced by the adrenal cortex, if aldosterone is increased, what happens? There will be increased sodium and water reabsorption and increased secretion of potassium and hydrogen into the urine. So this will increase sodium and water reabsorption. If sodium and water is reabsorbed, what happens? If sodium is reabsorbed, water follows it. Just learn it that way. Sodium is reabsorbed, water follows it. Sodium is reabsorbed, water follows it. Meaning that when you lack water, what happens? Renin is produced. Renin converts angiotensinogen to angiotensin 1, ACE angiotensin 1 to angiotensin 2. What does angiotensin 2 do? First of all, it will make the cortex to produce aldosterone, and this aldosterone will lead to salt retention. And when salt is retained, what happens? There will be retention of water, so dehydration stops. It will increase volume. And when volume is increased, what happens? It will increase blood pressure. Blood pressure will return to normal. Another thing that it does is to increase vasoconstriction of arteries, leading to increase in blood pressure. Another thing it does, you understand, is leading to increase in blood pressure. So those are the mechanisms. Another thing it does is to sensitize the hypothalamus. The hypothalamus will do what? We increase taste. And when you are thirsty, what do? You drink water. So this is the RAA mechanism, RAS, renin angiotensin aldosterone system. This is the mechanism it functions. So in your exam, they may ask you, renin is from which, is produced where in the kidney? Option A, juxtaglomerular cells. Pick that answer. They may ask you, what breaks down angiotensinogen to angiotensin 1? It is renin. Pick that answer. Don't make mistake. Pick the answer. I said you should pick the answer. And if they ask you, what converts angiotensin 1 to angiotensin 2? Tell them it is ACE from the lungs. Tell them I said. Now, if they ask you, what are the functions of angiotensin 2? Tell them that there are 3 major functions. 1 is increased aldosterone. 2 is it causes vasoconstriction. 3 is it sensitizes and hypothalamus. All these things to what end? For blood pressure to increase and return to normal. You can't miss out this. Now, let us discuss little things about the urine before we start discussing the questions. One thing you need to know is that the color of urine is as a result of urochrome. They will ask you in exam, what causes its color? Urochrome. Urochrome. Take pen and write it down. Urochrome. What does it contain? Creatinine. How do we check the GFR? We use creatinine to check the GFR, but we can use inulin. Why?
There's anything I'll do because I'm borrowing somebody's laptop today.
You're borrowing someone's laptop. Which person's laptop are you borrowing? Is it not something you can always do later? If I check it. My video was just interrupted.
He said he needed to get me frustrating.
Oh, she's traveling tomorrow. But wait, how many average rating? It has an average of 3.8 out of 10 from a total of 647 reviews on drug.com. 20%. Okay, this is good. Okay, this is good. This is good. Let me talk to you later. No, it's okay. So the color of urine, I want you to know, it's as a result of urochrome. I don't want to start explaining what urochrome is. Just write it down, urochrome. It's one of the exam questions. All right? Also, creatinine is used to check the GFR. Why? Because your body produces creatinine. And your body, the kidney is supposed to remove the entire creatinine. Maybe, it doesn't remove it 100%. It can remove it at least 99%. Do you understand? So what we should, if we find out anything above maybe 1.2, then as creatinine, then there's a problem in your kidney. All right? So those are the things we check. The creatinine is produced as a result of breakdown of some muscle tissues. But we have inulin. Inulin clears 100%. But inulin has to be injected, so we don't like it because it's invasive. All right, so just put this information in your head. And some people may ask you, what does the urine contain? It contains creatinine, ammonia, uric acid, dissolved salt, urea, hydrogen. Do you understand? These are the things that creatinine contains, that urine contains rather. So these are some of them. We mentioned them: sodium, potassium, sulfate, phosphates, urea, uric acid, creatinine. These are things it contains. Micturition is another question that we ask. Another name for micturition is urination, diuresis, and voiding. It's a process by which the urinary bladder empties when it becomes full. All right, it's voluntary control of an involuntary reflex. All right. Okay, so these are the phases of micturition. The trousseau relaxes, and from there you void. I just want to move so that we can consider the questions. Now, these are the steps. Bladder collects urine until it reaches 200 ml, stretches receptors, activates, trigger bladder contraction reflexes. Urine is first past the internal urethral sphincter into the upper part of the urethra, causing you to the urge to void. You understand? So if you postpone it, it will relax as well. So this information is very important. Normal volume per day is 1 to 2 liters. Now, when it is more than 2.5, it's polyuria. Polyuria is usually caused in cases like diabetes mellitus, even insipidus. You understand? Or maybe when you take excess caffeine, alcohol, kidney disease, certain drugs, like diuretics, even sickle cell anemia, excess water intake. These are the things that could cause polyuria. Typically in diabetic people, you understand, polyuria happens. You urinate a lot. Before you know it, the body, remember what we discussed, the body, the antidiuretic hormone, you understand, is triggered. Also, the hypothalamus is triggered. And if the hypothalamus is triggered, it makes you want to drink water. That's why diabetic patients, we say polyuria, polydipsia. You understand? Okay. So, but usually this can indicate kidney disease. Oliguria. They will ask you, what is oliguria? Oliguria is when the urine is abnormally small, 300 to 500 ml per day is oliguria. Male, not liters, male per day. When it is less than 15 ml, it's anuria. You understand? So if somebody comes to the hospital and the person says, hey, I've been drinking water, but I've not been urinating, then I'm suspecting kidney problem. I've been drinking water, but I've not been urinating. I am suspecting kidney problem. Do you understand? There are a lot of things that could cause it, but I'm telling you, I am suspecting kidney problem, especially if I check and the urine is less than 50 ml in a day. No, there's a problem. Sometimes it's also as a result of enlarged prostate. You understand? Okay. Now, there are some disorders that you can see in the urinary system. We have urinary calculi, you understand, which usually contains crystals of calcium oxalate, uric acid, or calcium phosphate. All right? These are stones. We call it renal stones. Renal calculi, renal stones. We have UTI, urinary tract infections. Some of them are urethritis, itis. Anything itis is inflammation. Itis, as I mentioned initially. So urethritis is inflammation of the urethra. Cystitis, inflammation of the urinary bladder. Pyelonephritis, inflammation of the kidney. All right? These are all UTIs. UTI is usually common in females, as I mentioned initially, because of the short length of the urethra. They will ask you, one of the following is a reason the women have more UTI than males. Please go to the option D. The answer is short length of the urethra. Short length of the urethra. So the symptoms, UTI, usually burning sensation, frequent urination, even lower back pain and bedwetting. All right, so just know this and know peace. We have glomerulonephritis, all right, which is the inflammation of the kidney that involves the glomeruli. Remember where I told you where the glomerulus is. If that's the problem, then we are talking about glomerulonephritis. That's the glomerulus of the nephron in being inflamed is glomerulonephritis. As a result, you'll be seeing blood and protein because that is the place that stops blood and protein from flowing. We also have nephrotic syndrome. You understand? This one is when there is a lot of protein in the urine. You understand? And hyperlipidemia. So a lot of cholesterol in the blood, phospholipids, triglycerides. We are suspecting nephrotic syndrome. It has its own features, how to differentiate from glomerulonephritis. But we are not discussing pathology here. Remember, this is physiology and anatomy. What is anatomy? Anatomy is location, location, location. Physiology is what? Function, function, function. So we want to know the right function for us to know when it is pathological. So what you need to know for this course is right function. That's physiology. Now, when you are talking about urinalysis in the hospital, as a nurse, as a doctor, they tell you, go and get me the urinalysis result or report of this patient. So the urinalysis is performed for us to be able to understand, the proper functioning of the kidney, if it is functioning properly or not. We want to analyze the physical and the chemical properties. This analysis will give us information to know if there is different problems, in the urinary system. It can be drugs, it can be bacteria. So when we find them, we will be able to understand. Normal urine volume, we discussed it already. What affects urine volume? Blood pressure, blood volume, temperature, diuretics, and mental state. Now, what is the color? We've already mentioned it. As a result of hemoglobin breakdown, remember urochrome. This pigment, urochrome. This pigment, urochrome. That's what they like to set in the colleges here in the US. So a lot of things affects it. Okay. Then sometimes when the urine is cloudy, hazy, or turbid, you understand, we are suspecting bacterial metabolism. So we are saying, oh, this person may have bacterial infection. Do you understand? Okay. Now, odor is also another thing that affects, urine, because usually urine has this ammonia odor. Sometimes if it's foul, if it's sweet, if it's fruity, if it's maple syrup-like, if it's rancid, if it's rotten egg smell, all these things are abnormal. It has to be ammonia-like smell. All these other ones are abnormal. You understand? It can be as a result of disorders, it can be as a result of drugs, it can be as a result of diets. All right? Now, the pH of the urine is 4.6 to 8. It's slightly acidic. You understand? The specific gravity is what they will ask you in the exam. Remember 1.025. Remember 1.025. Remember 1.025. It can increase or reduce. It's affected by solute particles and dehydration. 1.025, 125, not 125, but add 0, 1.025. All right? Okay. Now, sometimes we have protein in the urine. We have albumin in the urine. You understand? Protein in the urine, albumin in the urine, glucose in the urine. When there's excess glucose in the urine, there's a problem. Glucose should be reabsorbed. You understand? In the PCT. No, ketones also. When somebody has excess fats, you understand? Excess fats. So if somebody is starving for a long time, or having dieting, some kind of diet, or if somebody, has diabetes, it can lead to increase in ketone. You understand? So we have a lot of other things. You understand? We have maintaining balance and all those things. But these things are very, very important. I want to read out some questions to you. These are very, very important. I want to read out some questions for you to think about, for you to attempt. I want to read out some of these questions for you to think about it. They may ask you a question like, okay, hold on. So they may give you, so they may give you this kind of diagram and tell you that antidiuretic hormone, where does it target? This is one of your questions. Where does antidiuretic? Please, the answer is the collecting duct. The collecting duct. The collecting duct. The collecting duct. I'm repeating it severally so that you will remember. The collecting duct. Okay. So they can also ask you, which region? They can also ask you, which region of the nephron is permeable to water but not sodium chloride? Which region is permeable to water? Which region is permeable to water but not sodium chloride? The answer is descending loop of Henle here. So antidiuretic hormone affects here. Here is permeable to water but not sodium chloride. Okay, now let's go to some of the questions. I want to recap everything I've mentioned and also ask you a lot of questions also with it. Now I want you to look at this diagram, because this diagram is where majority of your questions are going to come out from. Look at this diagram very well. Let me zoom in to this diagram. Okay, perfect. Sorry. Look at this diagram very well. Look at this diagram very, very well. So if you can see this diagram very well, or should I get a better diagram? Let me see. Okay, I think this one is the best. Okay, now let's look at this diagram very well as a recap, because a lot of your questions is going to come from here. They may ask you questions such as, most water is reabsorbed. Most water is reabsorbed. Look, they'll tell you from this diagram, most water is reabsorbed from the filtrates by which region of the nephron? Where is water mostly reabsorbed from? I want you to know that it is from the collecting duct. It is from the collecting duct. This is where most water is reabsorbed from. Okay, now, as a recap, I want us to review everything with questions, all right? Look at this diagram very well, the renal tube. Look at it properly. One of the questions they can ask you is, most water, is reabsorbed from the filtrate by which region of the nephron? Which part of the nephron is most water reabsorbed? Reabsorbed. When you're talking about reabsorption, remember, it is what? The proximal convoluted tube here. Reabsorption. Reabsorption. So anytime they mention reabsorbed, just go here and pick. Pick. You understand? Oh, what am I doing? Sorry. So just go here and pick. You cannot fail this. You cannot fail this. This is where most water is reabsorbed from. Okay. They may also ask you, which region of the nephron is permeable to water, but not sodium chloride? Which region is permeable to water, but not sodium chloride? Where did I tell you that water goes out from here? Why? Because it is squamous. Only water goes out from here. But salt does not go out from here. Water goes out from here, but salt does not. Every other place that water goes out from, salt, it follows salt. But here, it's not following any salt to go out. It's just going out because of the salt outside here. You understand? Outside the tube, pushing water to come out. So this is the only place. Don't forget. So remember, I just discussed two questions, which is, where is water usually reabsorbed from? And also, which region of the nephron is permeable to water, but not sodium chloride? Another question they can ask you from this is, where does antidiuretic hormone target? Where does it target? ADH, where does it target? ADH is target here. This is where ADH targets. This ascending loop. This thick ascending loop. This is where ADH targets. Oh, sorry. If they ask you where ADH target, the third question is, they can ask you, where does ADH target? You understand? You should tell them that ADH targets here. This is where ADH targets. This part, the collecting duct. So, highest water is reabsorbed here. Only water is reabsorbed here. ADH targets here. These are very important three questions that you can know about. Very, very, very important three questions that you can know about. Okay. You can know about. Now, they can give you this diagram. Now, what if they give you this diagram? They tell you which vehicle, which vessel is aquate. Aquate. I didn't mention it. I don't know why I forgot to mention this. Listen, this is the renal artery, right? The renal artery enters and becomes the segmental artery. It becomes segments. Now, look at each segment becomes a lobe. You see? Each segment becomes a lobe. So these are lobar arteries, interlobar arteries. Now, if each lobe, comes here and becomes what? Aquate artery. Just like an arc. Now, this aquate artery gives rise to the cortical artery. So if they tell you how does it move, remember, this is how it moves, This is how it moves. Afferents, this one becomes the segmental, segments becomes the interlobar becomes the aquate becomes the cortical. So if they ask you, which vessel is the aquate artery? Which vessel is the aquate artery? Which vessel is the aquate artery? I don't think anybody can miss this. You understand? Aquate, arc. Remember, aquate. Say aquate. This is aquate. This is aquate. This is aquate. You see how it is? This is aquate. This one that looks like an arc. Why these ones? The cortical. This one's the cortical. This one's are the cortical. This is the interlobar. This is segmental. Okay. So another one that they can ask you, which vessel is the segmental artery? I've already told you segmental. Segments. You see? Segments. You understand? So, and segments. So this is segments. Why this? Interlobar. Okay. They can ask you which one is the cortical artery. You understand? See these little ones here that are in the, remember this is the cortex. So the ones in the cortex, it only makes sense that the one in the cortex is the cortical artery. Cortical. This is the arc. And the aquator. This is the interlobar. This is segmental. Okay. So other questions they can ask you is, how does the urine travel? If they give you this, they tell you how does the urine travel. You should remember, you see, that the urine travel from this. You see, this is the minor calyx. This is the minor calyx. You know, this is the major calyx. Then this is the pelvis. Minor, major, pelvis. You understand? Then if this thing is labeled ureter, so this, you see the urine, this is how urine travels. This is how urine travels. No, that's no peace. That's another question they can ask you. And they can ask you to name the structures. Remember, this is ureter. From the ureter, pelvis gives birth to ureter. Remember this, pelvis gives birth to ureter. What gives birth to pelvis? Major calyx. What gives birth to major calyx? Minor calyx. Minor calyx gives birth to major calyx. Major calyx gives birth to pelvis. Pelvis gives birth to ureter. I need you to be able to identify these diagrams. If you can identify these diagrams, then you are good to go. So they may tell you to identify these parts. You see, this is minor calyx. You see, this is minor calyx. This is major calyx. This is renal pelvis. This is ureter. Then to the bladder. If they tell you, you have to know these things because they will tell you to identify it. These things, I just gave you up to 4 questions. I just gave you up to 4 questions. Sometimes they may ask you about adipose tissues. About adipose tissues. So remember that these adipose tissues, this is the part that contains adipose tissues. You should be able to label it well. If you see it, it's always yellow. It's always yellow in complexion. Do you understand? Then also they may ask you things like how to describe the positioning of the kidney. You tell them that the kidney is retroperitoneal. Anything urinary system, kidney, ureter, urinary bladder, tell them it's retroperitoneal. 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 I'm repeating it again. Retroperitoneal. Do you understand? So you need to acquaint yourself with this. Another question. So they may also give you this diagram or maybe the diagram of a human being, and they will tell you where is urothelium found. Urothelium. 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 What do you tell them? This, ureter, thelium, bladder. Ureter, bladder. So this and this forms the urothelium. This and this forms the urothelium. Please don't mention kidney. Kidney is not part of urothelium. It is the bladder, the ureter and the bladder. The ureter and the bladder forms urothelium. Ureter and the bladder. I'm mentioning the whole lot of times so that you remember. Urothelium. Also, they may ask you, let me see, how does urine move in the ureter? You understand? Or they may tell you, okay, first of all, know that urine moves through the urinary bladder, through the ureter with peristalsis and gravity. So if they ask you, which of these structures does peristalsis occur? Tell them this ureter. This way it majorly occurs. That's how blood, it moves. That's how urine moves downwards, the peristalsis and gravity. All right? Also, they can ask you something about the detrusor muscle. If they ask you where is the detrusor muscle found, is it not the urinary bladder? Everybody should be able to answer this. You understand? So these very, very, very important questions that you could be asked. And because these are the questions you could be asked. Now, another thing I want to ask you is, the sympathetic, does it make, how do I ask this question? Sympathetic nervous system, does it cause the bladder walls to contract? Sympathetic? Does it cause it to contract? The answer is no. Remember what I told you about sympathetic and parasympathetic? I told you that sympathetic nervous system helps in activities, correct? Yes. Ask yourself, do I feel like pooing or urinating when doing activities? The answer is no. So if you don't feel like pooing and urinating when you are doing activities, that means sympathetic does not push those things. Instead, what pushes it is parasympathetic. So if they ask you if it's parasympathetic, yes. If it's sympathetic, no. So you have to pay attention to the questions. I'm teaching you how to answer questions. You have to pay attention to the questions. They may not ask you exactly these questions, but they may ask you things very, very, very close to these questions. You have to pay attention. If you have your pen and paper, please write down all these things. If you have your pen and paper, please write down all these things I am mentioning. Another thing they can ask you is, what could they ask you? If when you have disease, you understand that affects your corticospinal tract, whether it will affect your urinary incontinence. Yes. I'll teach you that in neuro. But the answer is yes. Yes. If you have any further questions, please drop that question in the comment section. I will do well to respond. All right? I will really respond to your questions. Another thing we want to learn is micturition. What is micturition? Micturition is what? Elimination of urine. So this is the question they always ask. What is micturition? Micturition is what? Elimination of what? Urine. Elimination of what? Urine. Another name for it is diuresis. Another name for it is voiding. Urination, micturition, diuresis, voiding. Please learn these things. This is the kind of question they will ask you, definitely. This is the question they will ask you, definitely. Another thing you need to know is that what are the things that are found in the ureter? What are the things found in the ureter? I should have shown you a diagram, but just bear in mind that you have the adventitia, you have the ureter, you have the layers of 3 layers of smooth muscle, you also have the 2 layers of smooth muscle, correct? So these are the 4 things you have in the ureter, but you don't have skeletal muscle. Do you have skeletal muscle? No. If you see skeletal muscle, tell them it's false. There is no skeletal muscle. Do you understand? So if they ask you if it is found there, tell them it is not found there. And the ureter, how does it enter the bladder? Does it enter the bladder from superior position? Yes. Superiorly? Yes. From inferior position? No. I want to show you what I mean. Okay, look at. You see? Look at the ureter. You see? How does it enter? This is the bladder. It enters, by the side laterally. How does the ureter enter? It enters this way. This one enters laterally, but superior lateral. You understand? Each of them enters superior lateral. Each of them enters. But does it enter from below? No. That's inferior. No. Remember that. Also, another thing you need to know about the urethra. You see? This is urethra. This is the urethra. This is the sphincter. This sphincter, is it part of the urethra? No. If you notice, it's a very different color. Look at it. Sphincter is not part of it. Sphincter is not part of it. Let me show you a better diagram. You see, this is the ureter. This is the urethra, rather. This is the external sphincter. It is not part of this, so you need to know that it's not part of this. Things that are part of this, the external urethral orifice, you understand, the orifices, you have the prostatic urethra, you understand, then you have the membranous urethra, then you have the spongy urethra. So there are 3 types of urethra. We have the prostatic, the spongy, the membranous, and also the extraurinary orifice. Do you understand? But is the sphincter part of it? No, the sphincter is a different muscle of its own. Know that and know peace. And also, you see, which muscle is in the bladder? Look at it, the detrusor muscle. I can't oversay this. The detrusor muscle. You have to remember this. Okay. I want to show you something very important. Something very important. Okay. I thought I have it here, but something very, very important, because they may ask you something about renal clearance. You understand? Tell them that renal clearance of creatinine occurs where? Renal tubules. Renal tubules. Renal tubules. Take your pen and paper and write it down. If you want to determine somebody's renal function, GFR, what do we use? Inulin and creatinine. Inulin and creatinine. But if they ask you which one we prefer, it is creatinine, because creatinine is produced in the body, but inulin is not produced in the body. And we don't like to go invasive, but because inulin, you have to inject it to the person. So we prefer creatinine. All right? But just know that inulin and creatinine, because they are cleared maximally in the body. The body does not use it for anything. Creatinine, inulin, for example, will be cleared 100%, but creatinine will be cleared at least 90-something%. All right? So mention the 2 of them. And, okay, so there's something I want to bring to your attention. If, for example, somebody comes to the hospital and complains, maybe he had an accident, how do you know? How do you know if that accident, affected the person's kidney, but did not affect the urinary bladder? How do you know? It is, by if the patient has albuminuria. Albuminuria. Albumin in the urine. Albumin in the urine. Albumin in the urine. All right? Albumin in the urine. Also, another thing you need to know is, if they ask you a question involving alcohol, how does alcohol stimulate the secretion of ADH? Does it reduce reabsorption? Answer is no. It does not reduce reabsorption. Instead, alcohol increases reabsorption. Alcohol increases reabsorption. It does not reduce reabsorption. It increases it. You understand? Please write these things down. Write these things down. If you check somebody's urine and you see a lot of sugar, what do you suspect? Okay, so this question, I wanted to ask you this question. If the kidney, you understand, if somebody comes to the hospital and the person is having, had an accident, and you want to know how, if the kidney is affected but not the urinary bladder, how do you know that? The major way to know that is by checking albumin in the blood, in the urine, rather. If you check albumin in the body, in the urine, and the albumin is high, what does it tell you? It tells you that that person has kidney injury. Why is it so? It is so because albumin, they are normally too large to filter out. For real, they are too large to filter out. So if there is a presence of albumin in the urine, it shows, permeability, that there is a problem, there's an increased permeability of the glomerular membrane. You understand? So this is actually usually due to injury, high blood pressure, irritation, toxin. I mentioned this earlier. So don't fail this question. Don't fail this question. This question is extremely important. Another question they can ask you is, when there is glucose in the urine, glucose is normally filtered, right? After filtration, what happens? There's a reabsorption. Blood takes back glucose. But the situation whereby a lot of glucose is going to the urine, that means that person has high glucose level. Meaning what? Diabetes mellitus. Diabetes mellitus. So if they tell you glucosuria, look for glucosuria, that's glucose in the urine. Look for diabetes mellitus in the option. Do you understand? But if they tell you that the person has accidents, injury, you understand, which affects the kidney but does not affect the bladder, please look for what? Albuminuria. Albuminuria. These are very, 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 very important for you to know. Albuminuria has nothing to do with diabetes. All right, so know that. So diabetes, you're talking about glucosuria, in case of if they ask. Now, another thing I want us to discuss is the volume. This is the volume. So to meet the definition of polyuria, please look for above 2 liters. Remember, normal is 1 to 2 liters. So above 2 liters is polyuria. Don't wait for 2.5 because your option can be 2.5. Your options can be 2. Please, it can be 2 or it can be 2.5. I don't want anybody to fail this question. All right? It's very, very important. And I also mentioned something very, 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 very important. Let me see if I can, if I remember. Yes, I remember mentioning something. The color. I told you about the color of urine. The color of urine is what? Is caused by what? Urochrome. The color of urine is caused by what? Urochrome. Urochrome. I really need you guys to remember urochrome. You understand? So when they are talking about physical appearance, I know why I'm mentioning it. I'm repeating it over and over and over and over again. The reason is because this is the kind of question they will ask you. They will give you all this cyanochrome, they'll give you multichrome, they'll give you a lot of things. Please, the answer is these pigments known as what? Urochrome. Look at it here. Urochrome. This is your answer. Urochrome. This is your answer. All right? Now, when somebody that is healthy urinates, is there sugar in it? No, there's no sugar. There is no sugar. What are the normal things that you can see in normal urine? You can see creatinine, you can see urobilin, you can see ammonia, you can see magnesium. These are the things that you can see in a normal urine. I mentioned it initially. Look at them, a lot of them. These are the things you can see in normal urine. But is there glucose there? No, because glucose should have been reabsorbed if that person is normal, except the person has diabetes. All right? Now, another thing you need to understand is the countercurrent mechanism. I didn't mention it much. But just know that if they ask you what is the purpose of countercurrent mechanism is just, to supply salts, you understand, salts to the renal medulla and also and also urea. So salt and urea to the renal medulla. Salt and urea to the renal medulla. Salt and urea is not nutrients, so it's not oxygen, it's not removing of waste too. Do you understand? It does not have anything to do with nutrients, oxygen, removal of waste. It is salt and what? Urea to the renal medulla. This question is very, very important because the truth of the matter is that the countercurrent mechanism, what it does is to recapture sodium What is sodium? Salt. Recapture sodium. You understand? Because the fluid is flowing in an opposite direction. Opposite direction. So sodium, opposite direction. That's the function of, that's what countercurrent mechanism does. Do you get? I know I didn't teach it here because, they don't ask a lot of questions from it, but remember it. Now, in talking about salts, so the salinity, you understand, gradient of the renal medulla. What maintains this is that just a medullary nephron. Remember, we are talking about countercurrent mechanism here. Countercurrent mechanism. Salts, correct? That's what I mentioned. I mentioned salts, that's sodium in the opposite direction. Salt and urea supply. Salt and urea supply to the renal medulla. So what produces it is, helps to maintain this salinity is what? The justa medullary nephrons. Write it down. Write it down, because you will see a lot of things. You will see tubules, you see convoluted, you see distal, you see proximal. Please remember that it is justa medullary nephrons. Now, talking about hypotonic and hypertonic, isotonic nature of the urine. When is the urine most likely supposed to be hypotonic? Is it when there is a lot of water or when there is low water? When there is a lot of water. Hypotonic, hypotonia, lot of water. Hypotonia, loss of water. Lots of water. Hyper, when there is reduced water, dehydrated. High solutes. You understand? So when the body's water volume is high, there will be hypotonic solution. That's why, like in the winter, there's less, you don't sweat. And a lot of water is conserved in the body. So what do? You start urinating diluted urine. That's hypotonic urine. Every time you are urinating, there's high level of urine in your body. And that is when you drink so much water. You understand? You start pouring out a lot of urine because there's high body water volume. All right? Okay. Now, if somebody's urine is too diluted, how does that dilution reduce? That is the function of what? The collecting duct. What does the collecting duct do? The collecting duct pushes those water back into the what? The blood. It pushes it back into the blood so that you don't become dehydrated as a result of filtration. Pushes it back. So remember, collecting duct is the particular part of the tubule that does what? Helps to reabsorb water. It helps to reabsorb water. It pours away what? Salt, but it helps to reabsorb water. So thereby making the water hypertonic, the urine hypertonic. Now, remember what I taught you about PTH, parathyroid hormone. Parathyroid hormone is potassium thrashing hormone. Potassium thrashing hormone. Potassium thrashing hormone. So what does it do? It helps to excrete potassium. It helps to excrete what? Potassium. So PTH, potassium thrashing hormone. I mentioned this. Everybody was laughing. Now, the last mechanism is water conservation. I mentioned it, correct? Yes. What are the things that helps to contribute to water conservation? Okay, let's just put it this way. How does the body try to hold water to itself? How does the body do that? The body does that by what? By the collecting ducts. Remember what I said before. The body does what? By countercurrent multiplier. The body does what? By what? The length of the nephron being long, giving enough room for water to leave the nephron. And also the countercurrent exchange system. So we have multiplier, we have exchange, we have the nephrons, we have the collecting duct. These are the things, the four major things that helps the water to conserve, the body to conserve water. Helps the body to conserve water. This is very, very important. Also, I mentioned nutritic peptide, correct? Yes. So how does the nutritic peptide work? Remember, I told you that nutritic peptide, that's the BMP and the AMP, they help to reduce the blood pressure, correct? Yes. So when somebody's blood volume pressure is high, they reduce it, they bring it down. How do they do this? One, they increase the filtration rate. Two, they inhibit sodium chloride absorption by the collecting ducts. Three, they inhibit the action of antidiuretic hormone on the kidney. And four, they inhibit renin-aldosterone secretion. I need you to rewind back and listen to these four things. Write them down. Remember them. Remember them. Because they will give you questions based on this. They may tell you which of the following is a method by which the NMP, ANP, or BMP, that's nutritic peptides, how do they reduce blood pressure if blood pressure is too high, or blood volume? Remember these 4 things. I don't want to mention them again. So just rewind the video and remember these 4 things. All right. Now, another thing I want us to discuss is ADH. ADH. What does antidiuretic hormone do? Diuresis is urine. Anti against urination. What does it do? So it conserves water. It reduces or decreases the urine volume. Don't forget. It reduces the urine volume. So it conserves water. Any other answer is wrong. Any other answer is wrong. Another thing they can give you in the option is it increases the osmolarity of the urine. True. True. It increases the osmolarity of the urine. Of course. Think about it. If it stops water, decreases the volume of water. So if the volume decreases, it increases osmolarity. You know, so you have to think about it and be ready for anything they give you. You understand? And remember, I told you something about this. You see, this place, this is the thick ascending loop. This is the thick ascending loop. Can water easily flow out from here? No. So that's why water is flowing out from the thin descending and ascending. This is where water flows out. Squamous epithelium, remember. But can it go out? No, this is impermeable to water. All right? This is highly impermeable to water. Don't forget. Now, I've mentioned this initially. Where does aldosterone work? Aldosterone works here. This is where aldosterone works. In case of they give you a diagram like this and tell you where does aldosterone work, it works in the distal, distal, and distal convoluted tubule, disterone. Do you understand? So don't get it twisted. Okay. Just remember that in this place, this loop. You understand? Now, there are some diuretics that work here. What do they do? So what they usually do is to reduce body water content by acting on the countercurrent multiplier system. I wish I'm able to teach you this. Maybe in the next video, I'll teach you the countercurrent multiplier system and also the countercurrent exchange system, because there are 2 systems. There are 2 different systems. They have exchange and we have the multiplier. So when you're talking about the multiplier, the loop diuretics are the drugs that we usually take. Loop diuretics are the drug usually given to, okay, look at it. This is the loop of Henle. It works here, all right? So this loop diuretics by countercurrent multiplier system. Write it down. Write it down. Now, what happens in the thick ascending limb of the nephron? The thick ascending limb of the nephron. Remember, I told you that, the potassium enters the cell from the interstitial cells. And how do they enter? They enter the sodium potassium pump. Sodium potassium pump. Remember, we are talking about this place. This place. So the potassium does what? Re-enters in the interstitial fluid. Potassium re-enters. So using sodium potassium pump, it re-enters into the interstitial, this place. All right? So potassium goes out from here. Okay. Another thing you need to know is the nitritic peptides inhibits sodium chloride. Oh, we discussed this initially. It inhibits sodium chloride, yes. When it inhibits sodium chloride, what does it do? It increases urine output. You understand? It inhibits sodium chloride. It increases urine output. We discussed this initially, so I don't want to keep mentioning them. Now, there's something we know as hypocalcemia. Hypocalcemia is when calcium is low. You understand? If calcium is low, what happens? It secretes parathyroid hormone. What does remember I told the PTH, potassium traction. So it pushes the potassium into the tubules and gets calcium back. You understand? So when there's low calcium in the body, PTH is produced. PTH jumps into the system, pushes potassium away, and gets calcium in return. All right? So it betrayed calcium. It betrayed potassium. All right? And another thing you need to know is that in the proximal convoluted tubule, there are a whole lot of things that we are reabsorbed. A whole lot of things reabsorbed. Like what? Like water, like urea, like sodium hydrochloride, like sodium, like potassium. A whole lot of things are reabsorbed. Do you understand? So things that are not okay. So let's talk about what happens in the proximal convoluted tubule. All right, a lot of things are reabsorbed. I've told you. Look at it. If you look at this diagram, you see reabsorptions. We have water, ions, and all organic nutrients are reabsorbed in this proximal proximal. But the distal, they are secretion of ions, acids, toxic drug, and all those things. But the proximal is reabsorption. So what is not reabsorbed? Hydrogen is not reabsorbed. We don't need hydrogen into the blood. We don't need it because it can increase acidosis. We don't want it at all. Do you understand? Instead, we push it out. You understand? So if they tell you which of the following is not reabsorbed or which of the following is reabsorbed, rather, they will list the things that are reabsorbed. Look for the one hydrogen. Hydrogen, we don't want hydrogen. It's waste. We don't want it. All right? Okay. Now, we've discussed the things that are absorbed. I told you, anytime you see reabsorption, please go and pick PCT, proximal convoluted tubule. Any reabsorption they're talking about, please pick proximal convoluted tubule. I won't say it more than this, all right? And also, another thing you need to know that active transport also happens in proximal convoluted tubule. Active transport happens in the proximal convoluted tubule. So, in short, majority of your answer will be proximal convoluted tubule. Remember it that way, all right? Now, also, if I mention, I hope you can see me. Also, what did we learn about this? Also, look at this diagram. What did I tell you about this? Renin is produced where? In the kidney by the juxtaglomerular tubules. Angiotensin converting enzyme is produced where? In the kidney? No. It is produced in the lungs. Angiotensin converting enzyme is produced in the lungs, not in the kidney. But renin is produced in the kidney. So remember this. So more about this system. If there is, look at this, if there is dehydration, sodium or hemorrhoid, if there is a decrease in blood volume or decrease in blood pressure, what happens? All these things happens to lead to what? Production of angiotensin 2. Everything leads to production of angiotensin 2. Angiotensin 2 now does all this. All right? So if they tell you what stimulates constriction of glomerular inlets, you understand? It is angiotensin 2. This angiotensin 2 causes vasoconstriction of arteries. Which arteries? It's always constricted. I told you, it will just go and close that big door. Afferent is always constricted. Afferent is always constricted. You understand? More than efferent. Oh, you saw it can also close the going out door, the little one. But the one that it wants to do more is the afferent constriction. But just know that vasoconstriction occurs. All right? Very, 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 very important. Also, know about that this is the hormonal system, of modulating the blood pressure and volume. Other mechanism is the one we discussed about, which is the nervous system. You understand? The sympathetic, parasympathetic. Another one is the myogenic mechanism under the feedback loop. Myogenic mechanism. When you're talking about myogenic, you're talking about the smooth muscle, tendency of the smooth muscle to contract when stretched. This contraction of the smooth muscle helps to constrict the afferent. This is myogenic mechanism. Remember, we have myogenic mechanism, we have renal autoregulation, we have myogenic mechanism, we have tubular glomerular feedback, we have the sympathetic control, we have the renin angiotensin aldosterone system. But when you are talking about myogenic mechanism, you're talking about smooth muscle. I told you myo is muscle. Muscle. That's how you'll be able to answer this question. You can't miss it out. Now, they may ask you another question. All these things we have discussed, is leading to what? Afferent constriction, vasoconstriction of the afferent. Vasoconstriction, afferent. Any option you see, please pick it. It is very, very important. You understand? So they may ask you if they constrict what? We reduce the filtration. Is the afferent. Why? Because afferent is a big door. Big door. So anything that, if you want to reduce blood pressure or increase blood pressure, it has to be on that afferent. Either you are constricting or relaxing. Because that's where we have the maximum impact. So always remember. So if they ask you which of the following reduce glomerular filtration rate, the rate is what? Constriction of the afferent. That's vasoconstriction of the afferent. Don't forget that. So angiotensin we know is produced in the liver. I've already discussed that. This is it. Angiotensin produced in the liver. You see, renin produced in the kidney breaks this down to angiotensin 1. In the lungs, we give ACE to break angiotensin 1 to angiotensin 2, which does all this. I don't need to keep going back to it, but that's how important that diagram is. Okay, so another thing that they can ask you is, the capillary has pores small enough to exclude blood cells from the filtrates. The answer is true. We've discussed this before. You understand? It is absolutely true. Do you get? So you can't fail this question. And also remember that messenger cells. So a little information I want to give you that fenestrated endothelium of the capillary has pores small enough to exclude blood vessels, blood cells from the filtrate. Correct? Yes. And also it has pores that excludes albumin from the filtrate. Initially I was mentioning only albuminuria. Now we are talking about blood as well. So the answer is yes. It excludes blood into the urine. So remember that as well. And also another thing I want you to know is that there are spaces between the glomerular capillaries. In those spaces, messenger cells are found in those spaces. Do you understand? Messenger cells are found in those spaces. Just know it that way. All right? It's very extremely important that you know it that way. And also know that filtration, remember I mentioned something about pressure. You understand? We have oncotic pressure. You understand? Then we have glomerular blood pressure. That oncotic glomerular blood pressure. True or false? False. The answer is false. Instead, it is the hydrostatic pressure or the glomerular blood pressure. You understand? That overrides the oncotic pressure. I mentioned it initially when I was talking about pushing people outside. So it overrides it by 10 millimeter mercury. So that 10 millimeter mercury helps to push out fluids into the tubule from the glomerulus. Correct? So remember that so that they don't confuse you. So that you are not confused. Also remember that the innervation of the kidneys reduces urine production. The sympathetic reduces urine production, while the parasympathetic increases production. I've said this thing before. I don't need to keep saying this. The sympathetic reduces. When you are running, everything reduces. Both digestion, both urinary. But parasympathetic is one that functions more when you are at rest, and when you are at rest, you want to urinate, you want to poo. All right. So these things you need to bear in mind. And also, before urine, the fluids that precedes the urine is known as tubular fluid. You understand? Tubular fluid. Because look at here. Tubular fluid. Why? Because if you look at this diagram, you see that filtrate enters here. This is tube before collecting duct, which is urine. Right? So all these things are tubular fluid that now precedes urine. All right? So you can't mistake that. You can't mistake that. Okay. Now there are sometimes they may ask you a question like you should trace the blood flow. You understand? They can tell you to trace blood flow from the renal cortex to the renal vein, or from the renal artery. You understand? From the renal cortex to the renal vein, or from the renal artery. But these are things that you necessarily cannot fail. Let me show you. Let me share this with you. Okay. Looking at this diagram, sometimes they may tell you to trace a blood flow. Oh no, here they may tell you to trace the urine. So know that it's from the collecting duct to papillary duct to the minor calyx to the major calyx to the urinary pelvis to the ureter. Do you understand? You have to understand this. Then sometimes they may tell you to trace they may tell you to trace the blood. Let me see if I can see a diagram for that. Okay, so it's not labeled, but let me help you here. So sometimes they may tell you to trace the sequence of arteries in the kidney. You understand? But remember, this is the renal artery. I told you this thing before. Renal artery now divides into segments. See, segments. 2 segments. Now, the segments, they divide into what? Interlobar. This interlobar. This interlobar. This interlobar. This interlobar. This interlobar. So different lobe has their own. Now, the interlobar now divides into what? Segmental to interlobar. Interlobar divides into what? Arcuate. This arcuate. This arcuate. This arcuate. This arcuate. This. So, divides into arcuate. And then the arcuate leads to what? Cortical. You understand? So this is the sequence. Like, you don't need any soothsayer to tell you. Do you get? And if they're asking you, how does it flow backwards? How does it through the renal vein? Because the artery and the vein, the same pathway, almost the same pathway. So what do you have here? It means that if they tell you, does it flow from cortex? Just know that you are starting with cortex. So any answer that does not have cortex as beginning, cut it off. You understand? That will drop the answers for you. So from the answers you have now, then just go backwards normally. So if this is the cortical vein, what will this be? This will be the arcuate vein. Arc. See the green one, the blue one. Then the arcuate vein will become what? The interlobar. Look at it here. This is Aquate, this interlobar. The interlobar join together to form segments. These segments. You understand? Then the renal and then the renal vein. You understand? So just trace it. This is very, very easy. This exam is extremely easy for you to pass. Understand? The only thing you need to understand is how these questions are asked. Think like the professors, think like the lecturers. In every school, as far as this is a college concerned, this is the kind of, so this anatomy and physiology, this is the kind of question they will ask you. Nobody will start telling you to, determine how the cortex functions exactly. No, nobody will start telling you that. Nobody will give you those kind of questions. As far as your question is sub-objective, this is the kind of questions you are most likely going to get. You understand? Sometimes they may ask you afferent, efferent. How does the transition occur? This is where it occurs. It occurs where? In the glomerulus. This is the renal artery, afferent and efferent. It occurs here, in the glomerulus. Remember, it is the glomerulus that it occurs. Don't make that mistake of choosing something else. Another way you can distinguish, listen, remember I told you that there is a difference between this cortical nephron and the just medullary nephron. How can you differentiate them? You can differentiate them because the cortical nephron is in the cortex, just medullary is in the medulla. Simple. So their location within the renal cortex is enough for you to differentiate them. It's as simple as that. Write this answer down. Write it down in case of if they ask you, because this is what they may ask you. Another question they may ask you is the percentage. 85% is cortical. It's 15% the justa medullary. But which one is longer? The justa medullary. Which one is shorter? The cortical. Which one is longer? Justa medullary. Which one is shorter? The cortical. Another thing they may tell you is, remember I told you that this thin descending lobe is the one that has the squamous. It's thin. It's thin. You understand? Every other part has, the cuboidal. Only this part has the squamous. Only this part has the squamous. Only this part has the squamous. All right? So another thing I told you is, this thing is squamous. Every other thing is cuboidal. All right? Every other thing is cuboidal. This part is squamous. They will ask you. They may tell you one of the following is squamous epithelium, or they may tell you one of the following is not cuboidal epithelium. Remember the thing. I'll keep mentioning it. Now, they may ask you the sequence. You understand? They may ask you the sequence, which I have already described to you. I don't think it's necessary for me to start telling you this sequence again. So if they tell you the major calyces, where did they enter? This is major calyx. Where did they enter? Renal pelvis. This is your answer. If they tell you the renal pelvis, where does it enter? Ureter. This is your answer. If they tell you the ureter, where does it enter? Urinary bladder. This is your answer. If they tell you the minor calyx, where does it enter? Major calyx. This is your answer. You get it? So I just want you to simplify it to yourself like this. Sleep, wake up. You are thinking about this. Now, there is this very beautiful question that I need you to know. There's a question they usually ask. You understand? They will tell you, oh, can you tell me the thing found in the inner layer of the glomerular capsule? What is found in the inner layer of the glomerular capsule? Sometimes it's wrapped around the capillaries of the glomerulus. It is podocytes. Podocytes are food processes that helps in doing what? They are food processes that helps in stopping the amount of, in terms of filtration. So they are part of the things that stops the albumin or anything above 8 nanometer. All right. So podocytes. If you see podocytes in an option, there's every possibility that that's the answer. And also know that the average kidney gives 1.2 million. I've mentioned it. Has 1.2 million nephron. And also a single lobe of kidney is comprised of one pyramid and one cortex. One pyramid and the overlying cortex. That's a single lobe. That's why we said interlobar. If you look at this, this is, is pyramid. You understand? So this is pyramid. See, renal pyramid in the renal medulla. This is pyramid. These things are pyramid. So a single lobe of a kidney is composed of one pyramid and overlying cortex. All right. So remember that. See, we move from very difficult part of the questions that they can ask you to the simpler ones. And also another thing you need to know is that the fibrous capsule, which I told you, this is the capsule. You see, this thing is the capsule. What does the capsule? See, this fibrous capsule. What does the capsule do? I told you that the capsule helps to protect the kidney and assist in pushing off infections. It protects it. Without the capsule, it's a problem. Capsule is like a cloth that the kidney wears. And if they ask you where is blood plasma filtered, it is in the renal corpuscle. It is where? Renal corpuscle, not renal column, not renal calyx, but renal what? Corpuscle. I mentioned initially. So another thing you need to know is that the helium is the part of the pelvis. I mentioned it is the helium, where the renal artery, renal vein, renal nerves, and everything, and even the pelvis exits. This is where they enter or exit. Anyone, just know that that is the helium. All right, that's the helium. It's just a medial concavity of the kidney. All right. Now, as a form of introduction, if they ask you, you know that the urinary system gives waste, correct? The skin, that's the integumentary system, gives waste. The digestive system gives poo, that's waste. The respiratory system gives CO2, that's waste. What is the waste given by the cardiovascular system? What's the waste? What of nervous system? You see, these systems, they hardly give waste. They don't give waste, correct? Because their waste are usually filtered. They don't give waste. So if they ask you which organ does not excrete waste, please choose cardiovascular system. You understand? Because it does not produce waste. And if they ask you which one produces waste, like nitrogen, digestive system produce nitrogen? No. What of respiratory system? No. It is the urinary system. Remember, I told you when there is too much nitrogen, when BUN is above 20 or 24, we call it azotemia, right? The person starts vomiting. It's a syndrome of vomiting, diarrhea, and all those things. Just remember the terminology. And remember that urea that we bring out in the urine is as a result of protein catabolism. Breakdown of protein gives birth to what? Urea. And nitrogen, as we said initially, that it's one of the biggest ways that the urine removes. If it's not removed, it leads to toxicity, which we know as azotemia. I mentioned it initially. You understand? So just learn all these things. Learn the function of the kidney. Learn that the kidney helps to, the amino acids. You understand? It helps in the elimination of amino acids, and also that you should know the organs of the kidney. You understand? And everything that is true and false about the kidney. So there are a whole lot of questions I mentioned. A whole lot of questions. I just discussed with you almost more than 80 questions. I need you to look at this video again and again. Do you understand? If you want to pass your exam, read your slides very well. Listen to your lectures very well. That's why I didn't go too deep. I hope it wasn't overwhelming. I hope you had fun during this exercise. Please, when you are watching the video, you can always click pause to write down these questions. Try to answer the questions before I answer them. All right? There are about 80 questions I discussed, even more than that. What you need is look for these different question banks and solve as many questions as possible. That's the best way for you to understand anatomy and physiology. All right? If you have any question or any comments, please put it down in the comment section. Click like, click subscribe, and click the notification button, because there are more videos that are coming on different topics. All right? And if you have any topic you want me to discuss, put it in the comment section. Share this link to all your friends in the college, any college at all. Share this link to them, and they will be thankful and grateful to you. See you in my next video, all right? We'll be discussing the digestive system properly. Have a nice one.